what I'd like to do is just introduce Dr. John Mcnaught. He's the medical director at Fertility Ontario, and that's here in London, Ontario. He's extremely passionate about his career and loves helping people build their families. He does a lot of outreach through social media and his website, and he cares passionately about making fertility funding available for Ontario, for people living in Ontario, and for all Canadians. So thank you, Dr. John Mcnaught, for joining us tonight.
Thanks very much, everybody, for coming out. As you know, this is a very important date in the history of fertility funding in Ontario and in Canada. It is April Fool's Day today, and that's why we've entitled this webinar Foolish Decision, is because, as a lot of people are not aware, Ontario and not Quebec was actually the first province in Canada to fund in vitro fertilization. On April 1st, 1994, they uninsured the service, which caused a ripple effect throughout our country. Tonight, we're going to examine that decision and the implications that sprang forth from it. I'm very happy to have two very credible experts on our panel today. One is Dr. Jeff Nisker, Professor of Obstetrics and Gynecology and Bioethics at the University of Western Ontario, as well as Carrie Stanford, who is the co-founder of Conceivable Dreams, one of the most active organizations in lobbying for equitable fertility therapy in Ontario and throughout Canada. For those of you who don't know me, my name is Dr. John Mcnaught. I run a fertility clinic in London, Ontario, and I am very passionate about equitable and accessible fertility care, not only for Ontarians, but for everyone in Canada. Tonight, we're going to have a talk by Dr. Jeff Nisker called Ethics and Social Implications of Policy on Public Funding of IVF. Followed by that, we're going to take a few brief questions for Dr. Nisker. And then Carrie Stanford from Conceivable Dreams is going to present why funding IVF makes sense for Canadians, discussing some of the health economics around IVF funding. And then we'll have a chance for questions specifically for Carrie, followed by some closing remarks and questions for the entire panel. I want to preface tonight's webinar by saying I know how upset, angry, and sometimes bitter people are about the status of fertility funding in Canada. Tonight we are going to empower ourselves through knowledge. We're going to set our emotions aside for an evening, and we're going to become better advocates for fertility funding. So please try and keep your questions even measured, logical. We're here to improve ourselves. I know that a lot of people are struggling with not having access to health care. Empowering ourselves through better information is the first step towards making a difference. So what we're talking about is a decision sort of jointly from the Ministry of Health and the Ontario Medical Association, which dates back to April 1st, 1994. At that time, in vitro fertilization, which at the time was only practiced in a few centers throughout the province, was uninsured by a small panel, along with such medically unnecessary procedures such as tattoo removal. We want to examine the legacy of that decision tonight, and I can think of no one better to present that information than Dr. Jeff Nisker. Jeff is a professor of obstetrics and gynecology at the Schulich School of Medicine and Dentistry. He holds and has held CHR and Genome Canada grants to explore the ethical and social issues of reproductive medicine. He holds a CHR grant exploring public engagement for citizen deliberation, and his national positions have included Scientific Officer of the CHR Panel on Ethics, Law and Humanities, Co-Chair of Health Canada's Advisory Committee on Reproductive and Genetic Technology, and Editor-in-Chief of the Journal of Obstetrics and Gynecology of Canada. He's been a member of the CHR Standing Committee on Ethics, the executive of Canadian Bioethics Society, the National Council of Ethics in Human Research, and also has written or co-written over 150 scientific articles and book chapters, as well as helped produce some very poignant plays. So with that, I will give Jeff his first title slide, Ethics and Social Implications of Policy on Public Funding of IVF.
Thank you, John. When John asked if I would do this, I never promised that I wouldn't be emotional, because this issue has outraged me since April Fool's Day in 1994. Most of those articles and plays that John has mentioned have addressed the injustice that was inflicted upon families in Ontario, and by inflicting lack of equitable access to fertility treatment in Ontario, it set a precedent for the rest of Canada. So I kind of feel passionate about this, and not promising to keep the passion out of this. Now, what I am going to discuss with you, I actually gave the opening evening keynote talk at the Canadian Fertility and Andrology Society this year, and this is what I spoke to the clinicians, nurses, laboratory personnel, and press and policymakers who came to my talk. What I'm only able to give you about a third of the number of slides, but everything that I'm presenting you, I actually presented in September in Ottawa to all kinds of people who, like you, can make things happen. So all these slides were in this talk. Now, I have to tell you that 9 years ago today, in 2004, our fertility clinic was celebrating 20 years. And so the London Convention Centre was, and when I say our fertility clinic, I had really nothing to do with the start of our fertility clinic. It was started by Albert Usby, who's now in Vancouver. So I can talk about it because I didn't start it or anything. And it was our 20th anniversary, and there were people in the room, all, hundreds upon hundreds, if not thousands of people, and children, and balloons, and clowns, and it was a huge celebration. And I walked in late because I was on call. And as I walked in the room, I almost fell over. It wasn't with joy from seeing all these children. All I could see was the children who weren't there. All I could see were the children who weren't there in the decade that had gone by, where people without significant socioeconomic means were denied the ability to have a child by a foolish retraction of public funding for foolish reasons. Now, you have to understand that the rest of the developed world, and when it comes to healthcare, I do not include the United States in that, but the rest of the developed world was publicly funding IVF. And our unit had created the second most families in the world in 1994. For the reason John said, there were only a couple units, and people from all over Canada would get an Ontario address so they could come to our unit. We didn't care. We just wanted to help create families of all types, of all natures. writing about this since April Fool's Day 1994, but it was just one of the most powerful moments in my life. And I actually walked back out into this mammoth corridor, this mammoth convention center, got out my dictaphone and started dictating a piece that I would write for the newspapers and for academic journals on what I was seeing and the disaster that had occurred in Ontario. Next slide, please. Because you see, public funding is a policy, and withdrawal of public funding is also a policy. And all policies have ethical and social implications. Our policies, because we do create policies with the people we vote for and how hard we stomp the streets and the people we lobby and the letters to the editors we write, we are responsible or should be responsible. Next slide, please. You see, we live in a justice-based democracy, okay? Unfortunately, it's not the justice-based democracy of Pierre Trudeau, where healthcare was the epitome of being Canadian. And yes, if we had to pay more income tax so that everybody would have equal health care, yeah, he just increased it. And we had, and this is not a political speech, because we had provincial premiers who were progressive conservatives, but they were red Tories, something that seems to have disappeared. So it didn't matter. The progressive conservative governments felt similarly that health care was absolutely paramount to being Canadian. Now, policies can be made by governments, it can be made by our professional organizations, it can be made by all kinds of organizations. And ultimately, the policies that we create shape health. The next slide, please. Now, justice is what I write about. And when you hear the word justice, most people think of a balancing scale, and they think of law, and they think of a woman with a blindfold. And that's only okay to some degree, because law-based justice can include slavery, the way it did in the United States until 1865. It can include things like men get to vote and women don't, like it did up until the 1900s and beyond, and in some countries it continues to occur. It can create things like fixed healthcare resources, which is an absolute fabrication. There is no such thing as fixed healthcare resources. We create the fixed healthcare resources by not willing to pay a little bit more income tax. When I talk about increasing income tax, I'm talking maybe 1%. To cover fertility, as you know, you don't have to increase income tax, but that will be the next speaker. Funding fertility treatment, we may actually, it's cost neutral or will save a tremendous amount of money, not only in the neonatal intensive care units, but in the supportive care of children born prematurely from multiple pregnancies. So law-based justice, it can be okay, but what's more important is justice-based law. Now, the picture that you see there is the Voice of Fire. This was purchased by the National Gallery in Ottawa. It's 3 stripes, okay? In several fundraisers where I've submitted it, I've copied it and sent it in, and nobody wants to buy it. But our National Gallery in $1989 paid $1 million for 3 stripes, okay? And they still have that. Now, they could sell that and create a whole bunch of families. And there's all kinds of stuff like that along the road. So this fixed resources is not looking at equality as essential to being Canadian and is not a justice-based law. Now, the next slide, please. So here's the Canada Health Act. Now, the Canada Health Act is a justice-based law, but it's missing something. So it is hereby declared that the primary objective of Canadian health care policy is to protect, promote, restore the physical and mental well-being of residents of Canada. Okay? Now, and to facilitate reasonable access to health services without financial or other barriers. So we have a law that's saying that we should basically deliver the same health care across the board. Now, of course, they got the science wrong when they stopped the public funding. They felt that the only thing scientifically proven was totally blocked fallopian tubes. If you had, many of our patients had very, very scarred fallopian tubes without any fimbria. But if somehow the referring physician pressed a little too hard on the hysterosalpingogram or methylene blue injection at a laparoscopy, and a little drop of dye came out those tubes, even though there was no fimbria or anything on the tubes, that woman would not qualify for IVF. They had to be totally blocked tubes. Nothing to do with male factor infertility, nothing had to do with unexplained infertility after a year or even 2 years, which was our highest success rate. Nothing to do with endometriosis or the many causes, okay? And considering that Canada Health Act talks about the mental well-being as well as the physical well-being, you know, I mean, for the sin of being poor, and it's not poor, it's just having no access to funds from friends or relatives or going door to door to collect enough money, that's discrimination, I think. Now, the next slide indicates that Quebec has now instituted an act respecting clinical and research activities related to assisted procreation. It's only in Quebec, okay? But there is now an act saying that can be referenced as something that the other provinces can look at. Now, talking about this for almost 20 years, people from the press or those who don't want to see public funding for their own personal reasons always say, well, there's all these babies that can be adopted, you know, and that's just not the case. And while I've done research on this, other people have too. It's very hard to adopt an infant. It's very hard to adopt a young child in Canada unless the child has a significant challenge. If you're wealthy, you can have international adoption if you don't want to go through IVF, and that's fine. But the same people that are discriminated against from public funding of IVF are also discriminated against for the same reason from international adoption, and they're also discriminated against from private adoption, even through the Children's Aid Society, because the birth mothers want a white picket fence around the home that their child is going to live in. The birth mothers have input into the placement of their child, and they want a white picket fence. They want wealthy, well-educated parents. Not always, but many times. So I figured if we could have an act in Canada like the rest of the developed countries had, that declared that in vitro fertilization was moral and ethical and a good, then we could reinstate public funding. So I spent 7 years of my life chairing Health Canada's Committee on Reproductive and Genetic Technology, which resulted in the Assisted Human Reproduction Act, which was not perfect, but which at least declared that things like cloning were bad, but things like IVF were good. As you know, there was a challenge from Quebec on this act as to who should be making the policies, and Quebec won. So provinces make the policy, but the prohibitions in the act are still the prohibitions in the act, and the things that are not prohibited in the act that are good, like IVF, are still there federally. And that's important. Cloning is still banned. IVF is still considered a good. But the actual policies will be made provincially. And they're important. Next slide, please. So when this happened in 1994, the first thing I did was write an academic piece that the policymakers have to read and all this sort of stuff. And I called it Rachel's Ladders. And I published this in Human Reproduction, which is a great big, there's like two big fertility journals. One is Human Reproduction, which is European, British, and the other is Fertility and Sterility. I chose Human Reproduction because I didn't think the Americans would know what I was talking about when I talked about equity in healthcare and reproductive medicine. And it was interesting, you get these reviews when you submit to a peer-reviewed journal. And so one of the reviewers said, I can't believe this article was written by a North American, because of course what I'm doing is talking about healthcare must be equitable. Doctors should not be asked to give suboptimal health care. Now, I chose the image of Rachel's Ladders. Now, it's sort of a biblical image because Jacob is, you know, I guess it was Abraham, Isaac, and then Jacob, the patriarchs in the Old Testament. And so Jacob fought this angel on a ladder, and he got a lot of press in the Old Testament. And you only hear a little bit about Rachel, his wife, one of his two wives. And what you learned about Rachel was that she was infertile. And people from all over the world pilgrimage, people of many, many religions, pilgrimage to Rachel's tomb on the West Bank to hope that Rachel will intercede for them. Anyway, what this paper talks about is that your wallet biopsy determines on what rung of a treatment ladder you'll get and what your chances of having a child. So if you're wealthy or have access or have a house that you can sell or something, and I know many people listening have gone through these machinations, then you might be able to afford IVF ICSI, and maybe you'll even be able to afford it for enough cycles until you have a child. And but most people aren't on that rung. Some people would be able to, it's IVF ICSI and cryopreservation of frozen embryos, okay? Some people will be able, next rung down, will be able to afford IVF and maybe cryopreservation. The next one is they can't afford cryopreservation. And the chance of pregnancy goes down, 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 down. Of course, it's dependent on what the etiology is, and everything is individual couple or person dependent, right? So I'm generalizing because I've got to stop soon, okay? And it's heartbreaking. You know, those of us who went to medical school in Canada. You know, I was at U of T, and the farthest thing from my mind was that we would ever practice medicine differently based on the size of somebody's wallet. It's just heartbreaking. So that was the first of many, many articles and plays that I've written and other ways to get at academics, health policymakers, and the public. So the next slide. So why haven't we been able, outside Quebec, to make this happen, to have public funding reinstituted? Especially now that there's so many articles that have come out showing that IVF works for many etiologies. And John has explained as to how we got into this mess, but let's go down to the second bullet point. Ed Hughes in Hamilton, a reproductive endocrinologist there, says that subfertile Canadians are largely invisible and poorly understood. I mean, it's great, the recent work, and I say recent because I'm looking over almost 20 years here, that Conceivable Dreams are doing and other fertility organizations getting out to the public, okay? Just getting out there, like in the empty strollers and things like that, drawing attention to it. But the public still is not really behind it, except maybe in Quebec, which tends to have the most progressive public. A bigger problem for me is the medical profession hasn't lobbied for it strongly, if at all. It's starting to be a little bit now, but I really felt that for most of these years that I was a voice in the wilderness. Jumping up and down, you know, this doctor from an ivory tower medical school who just, you know, believes in social justice but is not realistic about what things cost. Of course, as you know, wealthy Canadians buy their way around, you know, a policy that's not social justice based. And I'm also worried about neoliberalism migrating north. Now, neoliberalism is not liberal as we understand it. And again, I'm not talking politically. Neoliberalism is not progressive. Neoliberalism is the new type of liberalism that too many young people have, you know, that where they believe that the free market is everything and it's a sin to be poor. It's a sin to be socioeconomically advantaged. If you really wanted to be able to afford infertility treatment, you'd work harder. And of course, I'm just cribbing this because I don't have that much time. Now, the next slide is this article I wrote on distributive justice. And again, I can't really crib it down, because all these things are available on the internet and stuff. Distributive justice, based on a theory by a Harvard professor in 1971 in a book he wrote called The Theory of Justice, that says, if you don't know who you are, if you take an anamnestic drug, if you're in a cone of ignorance, the way he put it, and you make a policy decision without knowing who you are, whether you're rich or poor, whether you're a paraplegic or an Olympic athlete, whether you're a man or a woman, if you don't know anything about yourself, you will always create policies and vote for the least advantaged person you could possibly be. Next slide, please. Now, of course, the United Nations in 1994, by coincidence, issued a statement in the very famous Cairo conference that said reproductive health is a state of complete physical, mental, and social well-being. Okay? So let's get to the next slide, which is the Ontario Expert Panel on Infertility and Adoption Report 2009. Now, you can read this, but this report, in no uncertain terms, declared absolutely, this is a blue plate conference reporting directly to the Minister of Health of Ontario, and it said, Ontario cannot afford not to fund assisted reproduction. So it's bad wording, it's a double negative, but that's how they chose to do it. Ontario cannot afford not to fund assisted reproduction. Okay? And then they said Ontarians who could benefit, that's all Ontarians, should have access to assisted reproduction services. Now, unfortunately, soon after this report came the market crash, and our Minister of Health, who's a very good Minister of Health and very smart and knows these things, was not in a position to try to convince voters that this would actually save money. And it's just unfortunate, or she would have instituted it ahead of Quebec. Now, more recently, I took a different strategy and said, and wrote and spoke that access to fertility treatment should be a human right. And this is in the Canadian Medical Association. You can get it. And there is a case in front, hopefully, that will work its way to the Supreme Court soon, now in Human Rights Court, the Adirond case that you can access. And my last slide is the Conceivable Dreams slide, you know, that I found so powerful. The empty strollers, like the missing children, representing the missing children that I saw when I walked into that, to the London Convention Center. And I really would have liked to be there pushing an empty stroller, but I had some health issues and couldn't get there. I applaud Conceivable Dreams, and I applaud
Mel, can you go to the Conceivable Dreams?
for evening. Thank you.
Thanks so much, Dr. Nisker. I think what people don't realize is that Dr. Nisker has seen the life cycle of fertility therapy in Ontario. He was a member of the London Health Sciences group at a time when IVF was fully funded and the center was running 700 cycles of IVF per year. Since that time, since IVF has been delisted, the number of IVF centers across Ontario has not shrunk. In actual fact, it has sprouted to a couple of dozen plus from 3 or 4. So delisting the service has not created demand, or has not lessened the demand. It has only increased the price. At the same time, we know the demand for fertility therapy is ever increasing on the basis of social demographics, increased maternal age, delaying of conception, and environmental factors. People have not shied away from fertility therapy, but have, as Jeff pointed out in the concept of Rachel's ladders, they will access anything that is available to them. That's why there were 22,000 cycles of IUI in the province of Ontario in 2007, because people will gravitate towards anything they see as a ray of hope. What we want to talk about now is about the reality of in vitro fertilization, why it is the best available therapy for both Ontarians and Canadians, and why it, from a health and economics and equity standpoint, deserves to be funded in Ontario. We want to take a few questions for Dr. Nisker. Mel?
Now, right
Melissa?
now, I'm here. Can you guys hear me okay?
Okay.
Wonderful.
Yeah.
Okay, great. Right now, we don't have any questions, but this is everybody's chance to kind of type in a question. People were using that area really well earlier at the beginning to let me know that the screen was being cut off for everybody. So this is a great opportunity for questions. If you do have them, we'll get them answered for you. So this question's coming in from Catherine. She's wondering why more doctors aren't part of groups such as CD.
That's a very good question. I assume that every doctor would want to be part of CE. Whether or not they are willing to badger the Minister of Health the way I do. Maybe, I don't know. I can't for some reason think why not. But then I don't even know if I'm a member. But I
so Conceivable Dreams is a grassroots organization, and you are available to join as a member. I'm a member of Conceivable Dreams.
Well, I'd like to be a member. How do I join?
Well, I joined through their Facebook
answer those
page.
questions when it's my turn.
Yeah. I guess the question sort of speaks to Jeff. Why do you think doctors are not more vocal in terms of advocating for fertility therapy?
I think they're busy doing what they do. I think they believe their obligation is to the patients that they have and not other women and men who need assistance. So I believe that physicians have a moral responsibility not only to their own patient. I think generally we're pretty good with our own patient, although with assisted reproduction, we're not pretty good if dollars are added to the equation. We're not good at all, as a matter of fact. We give suboptimal care. Where doctors are not good and do not put their attention is in their obligation to the community at large. And I guess they figure people like me who are university professors as well as clinicians should do that. But that's not good enough because most fertility clinics exist outside of university environments. So really everybody should come together, and the CFAS and SOGC should be lobbying loud and hard and strong, and that's where war chest can be created.
Mm-hmm.
I guess answer the question.
Yeah, I think it is generally agreed that the medical community could do more. I think it's our role to choose the best available therapy for our patients, and if finances weren't an issue, in the vast majority of cases, we would choose in vitro fertilization with single embryo transfer. It's the right thing to do, and the issue is that in this two-tiered system that we've created, the money is getting in the way.
For sure. And I've got a question here from Patsy. She's saying, should we be careful of the wording? So much is about public funding for IVF, but maybe we should say clinically appropriate fertility treatment, so it kind of covers all the bases. Is that maybe something to consider or think about?
That's an excellent point. And if you look at all my articles, I even go beyond clinically to medically indicated. Although most of the time I use the word clinical because I include nurses and everything else. But when accessing the Canada Health Act, I use actually the language medically appropriate. Okay? So that takes away people that says, well, the next thing you know, these fertility docs are going to be recruiting 70, 80-year-old women to have children. there's all these criticisms that I've heard from audiences that I've spoken to about this, and that's not the case. This is medically appropriate. A doctor has said this is a possible cause for your infertility. The best, I use the word medical management. And of course, it is clinical management. That should be the right word. You're absolutely right. But because the Canada Health Act and other documents talk about OHIP, for example, is this medically indicated? That's the language. Is this medically indicated? And absolutely, and that's what I write in my article. And I'm sorry if I didn't use that today. I guess I feel I'm speaking to people who are like-minded, but I'm very glad you brought that up.
Yeah, it was a really good distinction. And this is a fantastic question. It's coming from Catherine. She says, what can we do as patients to help make a change outside of letters to monthly local MPPs and Deb Matthew? Like what kind of actions and things can patients be doing?
Maybe we should revisit that after our next speaker, because that's such an important question that maybe we should all talk about it together. Because Conceivable Dreams is already having a lot of activities. But I don't know.
Yeah,
Let's talk about that after.
Yeah, that'd be a great thing to talk about as a group, 100%.
I agree.
Mel, can you queue up Carrie's presentation, please?
For sure.
So next up is going to be Carrie Stanford, co-founder of Conceivable Dreams. Carrie is a former fertility patient. She works in the public sector right now. She is the co-founder of the preeminent advocacy group in Ontario, Conceivable Dreams. She organized the now famous 2009 Pram Push on Mother's Day, which was one of the best received public displays of support for fertility funding throughout Canada. She continues to work tirelessly towards the long-term goal of the organization, which is equitable fertility care for Ontarians. She has graciously agreed to speak to us tonight about some of the health economics behind in vitro fertilization. As I alluded to earlier, we know that fertility therapy, and I should say not just IVF, we should make that distinction. When people talk about the burden of things like multiple pregnancy on our system, those multiple pregnancies don't all come from in vitro fertilization. When IVF was delisted, people moved towards any sort of fertility therapy they could afford. And so you get superovulation with clomiphene, use of gonadotropins in intrauterine insemination, which actually contribute more multiples to the system on an annual basis than in vitro fertilization. The reason that IVF is distinct is because by transferring one embryo at a time, it is currently the only fertility therapy that has the ability to reduce the burden of multiple pregnancy. And Carrie's going to talk to us about that tonight.
Thank you so much for that kind introduction. What I'm going to do is I'm going to talk a little bit about the slides, and as we go through things, I'll also throw in a little bit of my own personal story, and I'll tell you, the listeners, a little bit about Conceivable Dreams as well. So the first slide, in case you can't read it all, what it says is the cost of multiples. And multiples, you know, it really doesn't make much sense at first glance when you look at this slide what that might mean, because really how can paying for a medical treatment like IVF save the government money and save us as taxpayers money? Well, what it boils down to really is twins. It boils down to twins and other multiple births, because if a policy of funding infertility treatment and IVF treatment is tied to a policy of transferring one embryo at a time, or at least educating women about the risks of multiple births, then fewer multiple births will occur and the health system will save money from that. In case some of you are still scratching your heads and asking yourself, well, don't twins save us money? Kind of like a 2 for the price of 1 deal when it comes to infertility treatment. Actually, no, it doesn't work like that at all. Multiples are 17 times more likely to be born preterm and to require a C-section and to need expensive care at birth and throughout their lives. And to help you understand this a little bit more, I'll talk to you about my own personal situation. In 2006, my husband and I, we conceived twins after an IVF procedure, including a procedure called ICSI, because our infertility was due to male factor infertility. And like most infertility patients and like most first or to-be first-time parents, my husband and I, we chose to implant 2 embryos. And to be frank, we considered twins to be a best possible case scenario. 2 babies for the price of 1 after we paid thousands of dollars to be treated for infertility. Sadly, one of my twins, she had a heart defect and she passed away in utero about halfway through my pregnancy at about 23 weeks. Luckily, I delivered her healthy twin sister at term in October of 2006. But that was after a high-risk, emotionally draining pregnancy that included 17 ultrasounds and included a C-section, not to mention, countless appointments with the high-risk team and everything else. I mean, I have no idea what my twin pregnancy would have cost the healthcare system, but obviously much more than a pregnancy that wasn't a twin pregnancy. Like I said, twins are 17 times more likely to be born prematurely, to require a C-section, and to require an expensive stay in the hospital in the days, weeks, and months after they're born. These numbers are much, much, much higher in the case of high-order multiples. That's triplets and up. Let's move on to the next slide. Thankfully, advances in medical technology mean that many twins born today prematurely survive and they ultimately thrive. However, neonatal mortality in twins is 7 times that of singletons, and twins are 4 times as likely to be born with cerebral palsy. We can move on to the next slide. On average, low birth weight twins will cost the healthcare system $1 million over their lifetimes. Multiple births create significant healthcare risks for both mothers and babies, and because of that, they're a major burden to our healthcare system. And this is where I get to, in a way, what is the saddest part of my story, because here I am 6 years later. I've been working as an infertility advocate for 5 years now, and I truly understand the really serious risks of multiple pregnancies for babies and mothers. And I really, truly understand the odds that even my personal odds back then of getting pregnant and of having a healthy baby would have been nearly the same if I had decided to implant a single embryo instead of implanting 2 embryos. And because of all that, I do think if I went back in a time machine and I had to make that decision again in 2006 about 1 embryo versus 2, I think I would only implant 1 embryo. But you know what? I'm not sure that I would. And that's what's scary, because if you're investing $10,000 or $20,000 for a one-time chance, or for what might be a one-time chance at being a parent, you're probably going to risk the twin pregnancy for those slightly better odds. And you're probably going to be thrilled when you find out that you have a pair of babies on the way. And that's the reality of the situation. Dr. Nisker said in his presentation that not funding IVF is a policy decision. And it's a policy decision that puts mothers and babies in this province at risk. Let's move on to the next slide, please. So I'll share a few things that we do know. And I don't think we can see all of this slide, so I'll try to summarize for you what it does say. But we know that a policy of public funding for IVF that is tied to a policy or practice of single embryo transfer in most cases will reduce the multiple birth rate. And this chart here that you can see part of, it shows you some of the numbers. When you cover the cost of treatment, the number of families choosing a single embryo transfer increases and the multiple birth rate goes down. And I don't know if you can read it, but the numbers here are here from Canada. So before, and this is just for Quebec, right, because Quebec is the only jurisdiction where IVF is covered. But before IVF was covered, then the percentage of families choosing to implant only one embryo was only 1.6. So that means 98% of families having IVF procedures done were choosing to implant 2 or more embryos. And to me, I was stunned even when I saw that that slide, and I've been doing this for a while. And once they started funding it, the number of families now choosing to do a single embryo transfer has come up close to 50%. And even, more importantly, is after the changes have made. Before it was funded, we would see 27% of the multiple birth rate from IVF was at about 27%, and it dropped really quickly down to 7%. I know that they thought it was going to take about 10 years to see that multiple birth rate get down below 10% in Quebec, but it was accomplished nearly immediately, maybe within the first couple of years. And Quebec is seeing the cost benefits from that very, very, very quickly. Another thing you have to understand about this situation is it's not just single embryos and double embryos, but if IVF or fertility treatment in general isn't covered and IVF treatment isn't covered, then families will choose other ways of trying to get pregnant first. Like they'll use a controlled ovarian stimulation cycles, and these are cycles that come with a high risk of multiples, and people will choose that instead of moving to IVF, which in a lot of cases is more successful, and where the number of embryos being implanted can be very carefully controlled. We'll move on to slide number 5. Next slide. In Australia, they saved $47.6 million in birth admission costs alone after starting to fund IVF. And Quebec estimates that they're going to see $30 to $60 million in annual savings. And what we're talking about here, these are just the short-term savings. This has nothing to do with the long-term costs associated with providing care for a twin with cerebral palsy or with respiratory problems or any of the other medical conditions that are associated with low birth weight and with prematurity. The expert panel on infertility and adoption, Dr. Nisker mentioned this, and this was a panel that was appointed by the Ontario government, and they presented their report in the summer of 2009 to study the issue of funding infertility and to make recommendations to the government. It was a highly qualified panel. It was chaired by our current Governor General, David Johnston, and Conceivable Dreams is lucky enough to have 2 former expert panel members sitting on our board of directors. That would be Dr. Art Leader and Jan Silverman, and both of whom have been working with us really since day one and been huge supporters and an amazing resource for us. Of course, we have already discussed what that expert panel recommended, but here are the cost estimates that the panel provided. The panel estimated $400 to $550 million in savings over 10 years in hospital costs. So these were the short-term savings that they expected to see, and then $360 to $460 million in long-term costs, and those would be like the cost of caring for children who have disabilities related to prematurity. There are many ways for the government to help with the infertility funding. There's lots of different models that the government might consider. There's full funding models, there's partial funding models, there's rebates and credits. In my view, and really this is my personal view, it's the full funding model that promises the greatest cost savings for us all as taxpayers and for the government, because it's full funding that removes a lot of the financial incentive for someone to implant multiple embryos or to use fertility treatments that run a high risk of a multiple birth, even though that medical procedure might have a much lower efficacy rate. Many patients and parents who are given all of the information about the risk of multiples will choose one embryo once the financial burden associated with the treatment is reduced. But having said all that, any financial assistance for the families and the people who are suffering with a diagnosis of infertility would be a welcome change and a welcome first step. And Conceivable Dreams, I mean, we really do support any measure that would bring some relief to people who are suffering right now. And there's really been nothing harder than to see so many families suffering with the financial burden, which of course just exacerbates the emotional and psychological burden of infertility. So really any change would be great, but I really do think the full funding model is what will make the biggest difference. And I think this next one is the final slide.
Yeah, and I was just going to, sorry, Carrie, I was just going to quickly wrap up because I wanted to open up the entire panel to questions. So we've heard from Dr. Jeff Nisker, we've heard from Carrie Stanford, and hopefully their message has been as clear to you as it has been to me. I'm going to sum up with three very clear points. Infertility is a medical disorder. Canadians are being denied access to medically appropriate health care. Funding and regulation of IVF has been proven to save millions in every jurisdiction it has been implemented in. And my question to the people who oppose this, to policymakers, and to you is, what questions do we have left to answer? Because in my mind, there are none.
Absolutely. I do have a few questions here, and I would really love to go back to the question about how patients can get involved in this outside of the traditional kind of write a letter to your MP avenues. I think this is an opportunity to possibly talk about the Conceivable Dreams Facebook page, because they're moving and shaking to get this this message out there. But I wonder, what else can people be doing so that they can have some power on the situation, know that they could make a difference around it?
Sure, I'd be happy to address that. And at the same time, I'll address, there was a comment made about doctors as well, and what more could doctors be doing, and why don't we see more doctors involved? And I don't want to minimize the role of doctors, because we have 2 doctors on our board of directors who have, and there are doctors out there who are in some ways leading the charge with respect to this issue. But you're right, and I think some of that might boil down to especially doctors that work for fertility clinics not necessarily, or feeling that there is a little bit of a conflict there, because of course, while they want to, for the benefit of their patients, they want to see this treatment covered, as access increases for this treatment, there is the potential for private clinics to be making more money as well. And I think there's always this there's a lot of optics there. And so infertility clinics and doctors who work in that area aren't necessarily going to lead the charge. It really is up to the patients who have this problem to lead the charge. And it's difficult, because when you're dealing with infertility patients, it's a small group of people at any given point in time, because you have a whole bunch of people out there who may have infertility problems in the future, but who haven't identified them or who haven't even started their family yet. And then you've got the people who are actively suffering with infertility and who actively need the assistance. And then you have everyone else who's either been successful and started their family, or maybe they've started their family through adoption or other means, or maybe they haven't been successful, but they're no longer actively trying. And it's trying to reach all of these groups of people and bring them together to speak with one voice, and to try to, to really reach a tipping point with the public so that people are aware of this issue and that people can be supportive of it and understand that we're talking about the health and well-being of mothers and babies, and that we're talking about saving the taxpayers' money.
Absolutely. And I think the conversation about saving money is not one, when this topic was introduced to me, I would have thought of, to be truthful. The injustice seems apparent to me, but taking into account the cost savings that this has, um, Dr. John Mcnaught, I think you made the best comment of what other questions are there really left to answer around this topic. So thank you for that. And I just actually pasted in, everybody, the Facebook link to Conceivable Dreams. I'll also be pasting in the link to Fertility Ontario, their Facebook page. There's a lot of active discussion around these types of topics, on both. So that's at least one little step to keep engaged in the conversation.
Yeah,
So
I would say to people, if you're trying to get out there and be an advocate for your own medical care, then start by reading the expert panel report, because you want to make yourself as educated as possible about this issue and really understand it. And when your friends and family ask, why should I have to pay for you to have a baby, that you're ready with the answer for why it makes sense. And and as far as Conceivable Dreams comes, we're the easiest group in the world to join, because all you have to do is go to Facebook and say, hi, I'm here, and you're a member, because we are as grassroots as it gets, and anyone who is a supporter of this issue is welcome to join us and participate in the activities that we're engaged in, to the extent that they're able to do that. There's a lot of people out there who are infertile and they're suffering in silence, and it may be that all you're able to do to participate is to be on the Facebook page and lurking and doing whatever, because you don't tell your friends and family about your problems, and that's great. That's okay. But come and take a look at what we're doing and see what you can do to help us out.
Yep, absolutely. And the links are down there for everybody.
I think that question that came up about what do you tell people when they ask why they should fund your fertility therapy? Quite honestly, the answer should be to them, you already are. Most Ontarians are not aware of the fact that most subpar fertility therapies are fully funded in this province. Again, I'm going to go back to the IUI phenomena. At 22,000 cycles, that works out to about $18 million a year. So our government is spending $18 million on one of the largest contributors to multiple pregnancy in our province. And it is because people are always pushing to increase the efficacy of an OHIP-funded procedure, which means more gonadotropins, pushing a little bit harder with medications, but ultimately you get a toll both in the short term and the long term. I think if Ontarians knew that they were already paying for fertility therapy, it would make more sense for them to pay for better fertility therapy.
And when people ask me that question, I'll give you this is the answer I give. Or if people ask me, like, why should I pay for this for people who can't have babies, or why don't you guys just go adopt a baby? Then what I say is, when my friend Joe, who's a 45-year-old rec league hockey player, goes and gets his knee scoped for the third time, nobody ever says to him, geez, Joe, I'm not sure we should all have to kick in for your knee surgery again. Nobody says that. And we certainly don't say to him, hey, why don't you just go take up shuffleboard instead of hockey? It is really fun. Nobody says that. I don't understand why fertility and infertility as a biological function is considered somehow a lower order of function than someone who needs their knee to play hockey or needs their elbow to go golfing or any of the other medical procedures that people need to have a quality of life. Infertility, as we know, anyone who's involved, it's all about quality of life. It's all about emotional, psychological well-being, and it's all about a bodily function that we have a right as people in Ontario to be treated for when it doesn't work.
Mm-hmm.
I wish I could be more optimistic about our fellow Ontarians. I mean, you've raised some really, really wonderful points, but I think we have to somehow do more like the Mother's Day walk and engage the press, make it so that they're basically shamed into doing that, or else use the law. If the Adirang case does succeed, and it's a year or two away from working its way up, but we could get behind that case. We could lobby the press. We could lobby fertility organizations. Make CFAS issue a political statement. As much as I'd like to think that our fellow and all Ontarians would say, well, this just is unfair, they haven't since 1994, even when it was in recent memory as being something that was publicly funded. I'm worried about neoliberalism. I'm worried about people who think, well, it's not going to be me, or people who think that I'll have enough, delay pregnancy, and I just think we somehow have to involve the media, whether it's around a Paradigm Court case or whether it's around a Mother's Day march, just to visually display how unfair this is, I think.
Yeah, don't you feel like that if you could talk to a person for 20 minutes, any person, no matter how obstinate, that you could convince that person of why this is such an important issue? And like, I would only have to introduce them to one or two of my patients to sway them. Unfortunately, we cannot introduce them to every single Canadian. The reason that I focus on Ontario so much is because the infrastructure in Ontario is already in place. Our government claims to fund in vitro fertilization. You know, they say that for one diagnosis, it is a medically indicated treatment. They discriminate against polycystic ovarian syndrome, endometriosis, male factor, idiopathic, hypothalamic. You know, there's a discriminant, because Ontario has decided that one diagnosis is correct and another is not, we're actually the greatest seed of discrimination amongst the country. But it also means that we are the closest. Go ahead, Jeff.
No, and that's what's being used in the human rights case. It's being argued in front of the Ontario Human Rights Tribunal that because IVF is funded for totally blocked fallopian tubes, it is discriminating against other Ontarians with other etiologies of infertility. That's actually how it's being argued, John. So you're right on.
Oh, it's the perfect
how it's
argument.
being argued.
And it's been successfully argued in front of the Canadian Human Rights Tribunal on that exact same point. And so hopefully, the fact that it's been a successful argument in the past means that that Amir Adirang's case it'll be found to be discriminatory, and hopefully that will put a lot of pressure on the government to act, and definitely that's going to be a point where everyone has to stand behind that decision and say, okay, it's time, along with everything else. I mean, John, you were saying you have to, how do we convince all of these people? And one of your callers said, well, what do we do besides contact MPPs? Well, we don't have to convince everybody in Ontario. We have to convince everybody in Ontario's member of provincial parliament, or at least most of them, because those are the representatives of those groups of people. We're never going to convince everybody, But that's the place to start. It's those MPPs who we do elect to make these decisions on our behalf. It's getting in their offices, having them meet the infertility patients, being there every year after year, meeting them, having infertility patients talk to them, educating them, and it's bit by bit chipping away at it. And that's why we need so many people to be on board and helping, because that's what we're trying to do day in and day out.
Absolutely.
That's great.
I have an absolutely fantastic, comment, or I think of another frame to put this conversation in. This is from Alana, and actually she wrote twice with two questions. I think they tie nicely. The challenge of discussing funding under OHIP and as a primary medical issue is that in some ways this excludes many gay and lesbian couples and Canadians who need funding to access reproductive technologies to start families. So, how do we expand the ways that we discuss funding in ways that can include access to reproductive technologies for all kinds of Canadians? As a perspective on this conversation that I don't think we've tackled quite yet, and I'll loop this in there as well. She asked about the Adirond case, and I guess really, if that case is successful, does that shed any light on how gay and lesbian couples will be handled inside of a possible decision? I'm not sure.
Okay, so that was a very important issue. I guess about 25 years ago, and brought to my attention by a lesbian couple who came in as patients and said, "Is there going to be any problem?" And I said, "Of course not. It's publicly funded. You want to have a child? We're going to help you. That's what we do. You're my patients." And it was publicly funded, no problems, nothing, because lesbian couples are single women, okay, women who choose to parent. It's because of the mental health part of the Canada Health Act. If a woman says, a single woman or a lesbian couple says, what will fulfill us psychologically is having a child, well, isn't that as important as, as anything else? It's because the Canada Health Act talks about emotional, psychological fulfillment, and it was never questioned when public funding existed in Ontario. It was never questioned.
And the expert panel report gave such a thoughtful discussion of a lot of those issues. I would definitely, ask the person who wrote to look at their discussion of it. And it's a really, really important aspect of this. And it is an area where, as an organization who's trying to push for funding, we are trying to get a lot of support because it's so integral to developing families for that community. And we get that. And it's hard. Actually, one of our biggest challenges is, someone earlier discussed language. And my goodness, when you're dealing with websites and Facebook, boy, trying to get inclusive language that really gets across what we're trying to, the people we're trying to support, but also keep things simple and snappy is very difficult. And we always want to make sure everyone understands that these are all issues that are really of vital importance. In fact, I think I'm going to make a mental note to myself to, when we're going to have a new website in the next little while with a blog capability, and I think that should be in one of our first few blogs, because it really is important, and it hasn't been front and center as far as our public and media presence. So I think it's a great point.
And I took out what is a family slides because I had to cut down to do this. But absolutely, what is a family? There are all different types of families, and that seems to be accepted. But it's a very good question and a very good comment. We have to watch that.
Absolutely. This question is coming from Amanda, And she's saying, if you pay out of your own pocket, wouldn't it be better to go for two babies, seeing how much the cost is compared to going for, just, using one egg compared to two eggs? And I know that kind of takes us back for, about 20 minutes in the conversation, but it's a good question. Like, why wouldn't you just go for two compared to one?
Well, it is a good question. I think part of it is that, and there are doctors here on the phone. I hope they'll chime in. But my understanding is that you're not doubling your chance of success by increasing the number of embryos that you implant, and you're certainly increasing the risks that are associated. And I think that is what I probably didn't fully understand when I chose to have two implanted. But I agree with the person who's written this question. It is very, very difficult not to do everything possible to maximize your chances when you're paying out of your own pocket. But I hope the doctors will address the odds.
Yeah, you know what? So I didn't make that point abundantly clear. So let me just frame that a little bit. So let's imagine there is no money, okay? You're not paying for your IVF procedure, and you have made 5 embryos or 6 embryos as a result of your IVF cycle. If you put back 2, perhaps you have 4 embryos available to be frozen or cryopreserved. If you put back 1, you have an additional, now you have 5 available for cryopreservation. What we find in the elective single embryo transfer data is that the cumulative pregnancy rate, the answer to the question of did you get pregnant, yes or no, is the same from transferring 2 embryos fresh as 1 fresh embryo plus 1 frozen embryo. The only difference is that the cumulative from fresh and frozen doesn't yield any multiples. And that's what drives the medical answer behind elective single embryo transfer. So anytime you reserve 1 embryo from fresh transfer, you have an additional embryo that can be cryopreserved and transferred at a later time. So your overall pregnancy rate is every bit as high, with limiting cost and risk to yourself as well as to the system that should be paying for your treatment. And this is the point that people must understand if we're going to move forward.
And just to underline that, there are clinics that if you can't afford the cryopreservation, it's not done. So you really don't have a choice, right? You have to have more than 1 transferred, because the rest are going to be wasted if you can't afford the cryopreservation and the storage. So as part of the public funding in Quebec, and I'm sure it will be in any other province that takes us on, you're funding the IVF, and you're also funding complete and total cryopreservation until the family is complete. Like, you're not saying, well, we'll only keep it in cryo storage for a year. It's until you are sure that you have completed your family. Then you can donate them to another couple or to research or have them discarded. So it's very, very important, the cryopreservation piece. Yeah, absolutely.
Awesome.
Yeah, it also does point to the one thing that I think we should address about the concept of funded fertility therapy in Ontario is, in all honesty, it is not really funded. If you happen to have your procedure done at London Health Sciences Centre, Ottawa Fertility, or Mount Sinai, your procedure will be funded by the government, but that still doesn't involve cryopreservation. It doesn't involve intracytoplasmic sperm injection. It doesn't involve some of the counseling fees. There really is no such thing as fully funded fertility therapy in Ontario. So when you get your form letter back from the Minister of Health saying that they're doing everything that they can, anyone who knows the situation in Ontario knows that that rings a little bit hollow. We have a long way to go towards appropriate care.
Great. Thank you. I just wanted to kind of go back to this question about the Adirond case. Um, if if that case ends up being won, how would that affect Canadians? Does that literally, if that case is won, does that literally make a funding available for all Canadians or just Ontario or just people in Ontario? I guess really what's hinging on that case right now?
Well, it's not really as simple as win and lose, for one thing, because it will depend a lot upon what they say. You could see where they could say, all right, it's not fair that you fund infertility treatment for one medical diagnosis, but like that bilateral blocked fallopian tubes, but not another. Now, you, Ontario government, you have to make this legislation fair. Well, now what are their options? Yes, they could fund it for many different treatments, or they could say, perhaps, okay, well, now it's not funded for that either. Now we won't fund it for anybody, if that makes it fair. It's not as simple as win and lose. It's not as simple as it's going to require immediate action. But hopefully, that I do have faith that the Human Rights Tribunal will see through those arguments and will understand that the issue is deeper and that this is about fair access to treatment for all people who suffer from this medical condition. So I'm not overly concerned about that kind of situation, but it doesn't necessarily mean, okay, we wake up the next day and we're all going to be covered. It's a chance. It will be put back to the government to try to bring the legislation into accordance with the Human Rights Code, and how that will ultimately look. It's not entirely clear. So the fight will continue, but it is important for everyone to be behind that case, in my view.
You see, unfortunately, it would be great if it could be kicked up to such a thing as a national human rights tribunal or on a federal level, but that can't happen in a health issue, unfortunately. This is specific, and it will only be on Ontario. But I think, if... I know there's a lot of action in Alberta right now, too, but it would just somehow, because it's a human rights tribunal, I agree, this is much more complicated than if it was a lawsuit, which was impossible, or they would have gone that route. But after a couple provinces see the justice, speaking to it from a moral rather than legal point of view, then I think it will become national policy because it's right. And, unfortunately, because it won't cost anything and will save money from the COHIY cycles for sure. And I think what's important is explaining, as has been said multiple times on this webinar, that, the woman in Vancouver who had the sextuplets, that was COHIY. That was not IVF. And that's like in the Rachel Slatters article in 1994. That was all predictable. I like to think that, on ethical terms as well as human rights terms and legal terms, that this has to be. And it's just shameful that it's taking so long.
It really, until I got involved in the advocacy side of things, I really didn't understand the power of communicating with the members of Parliament and face-to-face with our political representatives. And I really can't emphasize enough how important it is for them to hear it over and over and over again, because at the end of the day, until the political will is there, it is very hard for one of the mainstream political parties, for any of the political parties, to stand up and say, this is something we're going to get behind, because at the end of the day, it boils down to votes and where they think their votes are going to come from. and they need to it needs to reach a tipping point. It needs for the members of provincial parliament to feel that we can't be on the wrong side of this issue. We need to be on the right side of this issue, and that comes from pressure from patients and from people who are family members and supporters of the issue. It really is so important.
Yeah, and one thing that we know Canadians do believe in, and Canadians hold very dear, is the concept of universal health care. If we can establish fertility care again as appropriate medically indicated health care, we can draw upon Canadians' natural belief and passion for universal health care, because there is no politician that is going to stand up in front of his constituency and say, I do not believe in universal health care. If the issue is framed in terms of universality, it will have a greater, broader appeal.
100%. I have one question here. This is from Sandra. This is actually maybe framed towards you, Dr. John Mcnaught. She's saying, is the success rate lower with frozen embryos versus a fresh transfer? Also, isn't the attrition rate on reviving frozen embryos quite high? So it's a little bit more of a medically specific question.
Yes. Okay, so that's an answer that's currently in flux, and the reason for that is the technology around cryopreservation and thawing is changing very rapidly. So, some patients have messaged me and said, I hear frozen is now better than fresh, and what's going on? So we're moving away from a technique known as slow freezing to a more rapid freeze called vitrification. Vitrification causes less damage to embryos. They both freeze and thaw better. So we're seeing much better pregnancy rates from cryopreserved embryos than we were previously seeing. That holds true for sperm, and it also holds true for frozen eggs as well. So there may be a point where a cryopreserved embryo has an equal or greater pregnancy rate associated with it than a single fresh embryo. And that's a really hard thing to get your head around, because traditionally frozen embryos have had about half the pregnancy rate attached to them as fresh embryos. But you have to remember that when you're transferring two embryos up front, generally you're taking the pick of the litter and putting them into fresh embryo transfer. So the lab will preferentially always select your best embryos for fresh transfer, so the data is somewhat skewed. It's very much a conversation that's in evolution right now, but our pregnancy rates from frozen embryo transfer across North America and Europe are higher than they have ever been in the history of fertility therapy.
Thank you, John, for answering that. And we don't have any more questions now, but there's just one comment that came in. Sometimes we don't always get questions. Sometimes we just get comments. And this is from Melinda here. And she says that she just wanted to thank all of us for contributing to these webinars. She listens with her husband, and she really finds them helpful. She's liked Conceivable Dreams on Facebook, and she's really happy to know that she's not alone in this, that there are people out there that are going through the same thing and discussing such an important topic, and and that there is support groups out there. So Linda, thank you so much for making that comment. I wanted to share it with our expert panel here, because these webinars really make a difference for people, and they share such fantastic knowledge. So for everyone to take time out of their evening tonight is absolutely wonderful. I want to thank you for doing that.
Okay, well, if there aren't any further questions, I really want to extend my heartfelt thanks to Dr. Jeff Nisker and to Dr. Carrie Stanford for bringing so much to their presentations, both in terms of their knowledge, but also their personal experience. I was deeply moved by both presentations. I thank you so much for giving of your time tonight, and I think we all benefited from it, so thank you very much.
It was my pleasure.
Wonderful. And to everybody joining us, we are going to be posting this up on the Fertility Ontario Facebook page, so a recording of this. So this is our opportunity to share it so that other people kind of know what's going on. And there might be a few other pieces being posted on there, including the link to the expert panel report, which I know a few people requested. So we'll get it all up there so that we can continue to learn about this topic and continue to advocate even after this webinar.
Yeah, if you really dig on our Facebook page, I did post the expert panel report about a year ago. It's way back in our timeline, but it is up on the Fertility Ontario Facebook page. I will try and repost it. We're going to fix the video presentation to queue up with the audio so that hopefully when we put this onto YouTube, it will come across a little bit more seamlessly. Thanks a lot for your patience with the video presentation. I'm really sorry about that. So we're going to wrap up. Thanks so much for attending. I know that this is a huge journey for everybody, and hopefully over the coming year we're going to make a difference. So thanks very much, and we're going to wrap up.
Wonderful. Thanks, everybody. Have a really fantastic evening. Good night.